Welcome to the next in our webinar series, Back to School and COVID-19 Lessons Learned. As a reminder, please keep yourselves muted and your cameras off to preserve bandwidth. But where we would love your activity is actually in the chat. We want you to post your questions. The moderators will be monitoring that, as well as the other faculty members. So we want to make sure we get all your questions answered tonight. As a quick disclaimer, this is information that's not necessarily the position of the Aesthetic Society. However, it is information relevant as of today, August 25th. And this will be recorded and posted on surgery.org in the COVID section of our website. It's the purple banner on the home screen. So please go to that area. You can watch this webinar again, as well as view all of the weekly updates that our COVID task force pushes out every Friday to your email. So with that, I'll turn it over to our moderator, Dr. Bill Adams, our President-elect and Education Commissioner. Bill?
Thanks so much, Sue. I'd like to really welcome everybody to this aesthetic series educational webinar. I think it'll be a great hour. We have some great panelists that you can see here. So we've got Dr. Brad Calabrese, Dr. Mindy Hawes, Dr. Heather Furness, Dr. Steve Dottlebaum, and Dr. Tom Wiener, and then finally my Education Commission Vice Chair and Program Chair, Dr. Jamil Ahmad. So I think that you'll find this quite an interesting webinar, and we've actually all decided to dress in our favorite pro sports team paraphernalia. So if you're wondering what that is, that's the model. So what I'm going to go through in this hour, what we'll go through is the program here, and there's going to be two presentations formally by Dr. Wiener and Tattlebaum, and then some clinical perspectives from our clinical experts, and then some Q&A, and please do submit any questions into the chat. And finally, we want to give you an education update because there's been a lot changing, as you know, in the past 8 months, and we have some great stuff coming up. So Jamil will review that with everybody. You heard the disclaimers from Sue, so I'm not going to go into that further. And without further ado, I want to turn it over to Dr. Tom Wiener, who just published a paper in the Aesthetic Surgery Journal on this subject, and he's going to talk to us about what we didn't know then and what we know now. So Tom, thanks so much.
Thanks, Bill. And of course, that paper was actually written by you, and I was just doing some good data study on that. This is a real important key, and everything that I want to tell you, I think needs to be said in the light of any potential future pandemic, or more importantly, every year for the seasonal flu, because you need to understand it from a perspective we can grasp. Next slide. So the coronavirus spread and transmission, just going to briefly go through this. Early on, it was really unclear how this virus was spreading, especially when it was still limited to China. As time went on, it was clear that, especially in a healthcare setting such as an ICU, the actual aerosol transmission versus the droplet transmission. The aerosol, where it's suspended in the air, became the key mechanism that this virus was spreading, and that's why you saw these young, healthy healthcare workers in ICUs getting sick, is because they had, and this is another important term, a high viral load. This is true of any virus, almost anything we talk about, including capsular contracture. It's the load of the offending organism. So the epidemiology showed that this entered the U.S. From China, or initially showed this. But now we know that a large inoculation actually arrived from northern Italy. Now, northern Italy is the #1 travel site from China outside of the U.S. And as far as the United States, travel from northern Italy to New York is the highest travel volume. It's the largest Italian-American population. And so New York got hit very hard because also the two hotspots for travel from China to the U.S. are Los Angeles and New York. New York being, I think it's number 1 or number 2. So they got hit hard from both sides. So once again, a high viral load in a dense population. So the first U.S. case was on January 20th of this year, but it's now felt in a number of studies that the virus entered the country in December and probably in early December. Now, there are also some researchers who may actually have indicated that this virus was present even earlier than that. The seasonal virus for 2019-2020 was the second busiest viral season ever on record. So there is some thought that those numbers were bumped because of coronavirus. Next slide, please. So this just shows the travel. You can see Wuhan traveling to northern Italy, and also the green line to Los Angeles, and then northern Italy to New York, and Los Angeles and Wuhan to New York. Next slide. So infectivity, mortality, this was a huge question. Could someone who's asymptomatic transmit COVID? At first, it wasn't just unknown, but there were many who thought that there was no way it could be transmitted. And then there were others who thought that the transmission would be an extremely high percentage from those who are asymptomatic. We obviously now know that the majority of the transmission is actually from asymptomatic people. Can immunity be developed? There's a lot of interesting stuff going on right now. Of course, at first, because of previous experience with coronaviruses, it was felt that immunity would not be developed, or else it would be very short term. Now the studies are showing that not only can you develop IgG, but there is a T-cell immunity that is even longer acting than the IgG immunity. And that's given, and actually that's kind of on the forefront, and that's why the vaccine development had such a positive impact currently. How deadly is it? Well, you remember back to March, people were, and the media was quoting rates as high as 5 to 8% or even higher, that were millions and millions were going to die in the United States. There were outlets that said that. But the key here is you have to look at the at-risk population. You can look at the total population for numbers, but you have to look at the at-risk. And this was the thing that was problematic, even starting out in Wuhan, China, and then moving to northern Italy and then to the US. This was not focused on as well. And it was also not understood as well, but the at-risk populations were key. Can someone get reinfected? The initial South Korean study that showed people getting reinfected turned out that it was a false positive because of viral particles. Now, you've seen in the media just recently that there are 2 patients worldwide who apparently have gotten reinfected. There's no clear data on those 2 patients. Could we have done this better? This is the big deal that everyone missed. People looked at the Diamond Princess, they published on the Diamond Princess, but in reality, this was not studied to the point of it being a microcosm of everything that happened. So every patient on board was tested, 17% tested positive, 328 of those 634 were asymptomatic. Those with symptoms, overall mortality was 1.9%. Those who tested positive, mortality was 0.91%, and age 70 or older mortality was 7.3%. But this was a worst case scenario. This was an older population and it was crowded in a cruise ship. This is the thing that could have told us that the mortality was not going to be 30%. 40%. This told us what we could have done to prevent a global shutdown of the economy and a shutdown of even medicine. Next slide. In the office, in the operating room, what do we do? Masks in the OR, and I'm not talking about the ICU. The ICU is a different world, different study for a coronavirus ICU. Surgical or N95, there are obviously differences shown in the lab, but as far as infectivity in the real world in a non-coronavirus ICU, there's not as much data showing much of a significant difference. So what this tells you is that if you're not wearing an N95 mask in the OR, and I am not, your risks are probably not very significant. It all has to do with viral load. ICU, high viral load for COVID patients. In a normal ICU, unless you're doing a bronch on a COVID patient, it's not going to probably be that high. Next slide. And of course, this is the paper that Bill and Rafael Cotto and myself did. These were patients that were in a surgery center that Bill and Rafael work in. I did some of the data analysis for the paper, and what it showed is that 300 elective cases were done. No COVID symptoms appeared post-op. Next slide. And what was done in the protocol was 7 days prior to surgery, patients self-monitored. They were instructed to call the office of any symptoms. 3 days pre-op, phone call from the office asking if they have symptoms, did they travel anywhere, any contact with COVID patients. So patients and the staff both wear masks. Screening is via temperature check and a questionnaire for symptoms. Testing was not done. I use this protocol in my office as a little bit of variation that I use if anyone wants to contact me, but it's very similar. I do not test pre-op. I screen, and also I'm not operating on high-risk patients. I'm not doing a 15-liter liposuction on an 85-year-old patient. Next slide. So what if a patient or a staff has tested positive? What do you do? There are lots of resources, the Aesthetic Society, ASPS, American College of Surgeons, but the one that seems to have the most common sense and easy to follow is from the CDC, but it was modified and built on by the Texas Medical Association. You can see on the left their article that came out a few days ago. Doctors note negative tests should not be required to return to work or school, TMA says. Next slide. So what do they recommend? 10 days have passed since the onset of symptoms. Okay, so 10 days after the onset, and also at least 24 hours have passed since fever is gone without the use of fever-reducing medications, and other symptoms have improved. Now, this one is important. So when I had a really full-blown flu a number of years ago, I felt like crap for over a month. I wouldn't want to get an elective surgery during that time. I felt like crap, even though I still didn't have the flu. My body was not in a condition to be operated on. I was not up to par. Don't operate on patients who are still feeling like crud after the flu or after COVID. No additional testing is done or a doctor's note are needed. So that's really the bottom line, and that's backed up by the CDC and the TMA. If that's one slide is the most important, and thank you very much for your time and attention. And the hurricane coming in should have been named Rona. Damn it.
So Tom, one quick question before we move to Steve, but I mean, what do you think? There was a lot and so much talk and almost hysteria on the part of some lay people, but also some surgeons, in April about, what we're going to do. Is there one thing that you think that we didn't know then that made a lot of us concerned, but now we're just not worried about?
Yeah, well, if you recall back then, and to let you all know, the Texas Society of Plastic Surgeons, we have a WhatsApp group that we've been on for quite a while, and everyone was pinging back and forth. Oh my God, what test do I do? Do I do IgG, IgM, the PCR test? Everyone was so concerned about testing, and everyone had to test patients prior to surgery. Now we know that it is evaluation of symptoms, fever, symptoms that patients are having. If you want to do a pulse ox, just a fingertip pulse ox, you can. I'm not sure that even that's necessary, but that's really the main take-home message, is that for most patients when they're in the proper age group, they're low risk. These are not patients with COPD. If they're healthy, in proper age group, and properly screened, you don't need to test pre-op. That's the message.
We're going to have more discussion on that, and I'm going to go to Steve. So Steve Teitelbaum is in Santa Monica, California, well known to many of us. Steve's part of the COVID-19 Society Task Force. These are the members, and they've been working hard through the pandemic to provide information to you, and you probably have seen some of the weekly emails that you get from the COVID Task Force, so we thank them for their hard work, and Steve's part of that. And Steve has really spearheaded a number of surveys on the practices of plastic surgery and COVID-19, both through the LA Society and the Aesthetic Society. So Steve, thanks for presenting your data, and take it from there.
Thank you, Bill. Thank you, Jamil. Thank you, Sue. And I'm happy to talk to you today. Next slide, please. I'm going to present the results of a survey done by the Los Angeles Society of Plastic Surgeons. John Diaz is their president, and he's written this up with me, and Robert Singer also wrote this up with me. So going through the timeline, we remember early in March, the country was in a panic, not knowing whether we were going to exceed the hospital capacity. So by mid-March, most surgery was shut down throughout the country. But by the end of May, at least in Los Angeles, we resumed operating again. Next slide. So Bill already talked to you about this task force, and I think that Jim Furneaux has done an amazing job, and he should really be called out for that, as well as past President Charlie Thorne and current President Herlif Lund. If not for those three people, we don't know what we would be doing now or where we would be at, but the very good numbers you're about to hear, I think, are in no small part credit to what those three men have done. Next slide, please. So the Aesthetic Society Task Force put out inchoate recommendations, but we still didn't know whether it would be safe. Would patients develop serious infections after surgery? Would staff get infected? And would patients get infected from the procedure? Would it be safe? And we didn't know. Next slide, please. We were worried by a couple of papers, one from Brescia, Italy, and the other from Wuhan, that looked at patients who had surgery, who developed COVID postoperatively, and went on to die at much higher rates than historic controls. Now, these patients actually weren't tested beforehand. We don't know if they had it at the time of surgery or not. They were older and had more serious operations than we do, but it was something we were concerned about. Since we reopened, there have been two papers that we know about now. There's the paper that Tom already discussed, so I'm not going to repeat that, but suffice to say, at current, there are 1,500 patients in the surgery center in Dallas that have had elective surgery without any complications or without any testing. There's another study of orthopedic surgery from Holland that also did not do testing and showed no postoperative severe COVID cases. Next. But what actually happened with just plastic surgery in this country? So LA Society of Plastic Surgeons did a survey monkey to plastic surgeons in Los Angeles on July 16th through July 24th, which asked them about their surgery since they reopened, which had been then about 9 or 10 weeks. There were 112 respondents from LA County, about half of them from Beverly Hills, 20% of them from Los Angeles, and then a smattering from other cities. LA County has 108 cities. This is a very important slide because the purple shaded area shows you the daily new cases during the time that the cases were sampled, the new COVID cases, during which time the plastic surgery cases were sampled. And this shows that the results we obtained occurred during a period of a precipitous rise, during which there was discussion of having another stay-at-home order. Next slide, please. This shows the daily test positivity rate during the time course. When we started operating in May, it was at 4%, and it went to a high of 9%. It's now back around 5.5% in Los Angeles. So we're already on the back end of this rise, but these cases, the data you're about to hear, were collected during the rise of this. Next slide. This whole area is Los Angeles County, and the circle shows roughly the area where most of these cases came from. And it's interesting because it's obviously not homogeneously distributed through all neighborhoods in Los Angeles. And so we did not ask, because it wasn't practical to ask where every patient lived and where every staff member lived and where every physician lived. But the numbers you saw on the previous 2 pages reflected a total number of cases for the entire county. Next, please. So we first asked about whether people did preoperative testing. 92% of these Los Angeles surgeons tested everyone. 8% tested about 81% of the cases, and 2 surgeons didn't test anyone. So we got responses about 5,633 total operations, which is a lot for a survey. of which 95.5% had a preoperative test and 4.5% of the cases had no pre-op test. After surgery, still before surgery, there were 41 positives of the 5,881 total tests done, which is 0.69% positive. The whole county varied from 5 to 9%, but that included a lot of symptomatic patients. So what happened after surgery? After surgery, only 7 patients tested positive in the first 2 weeks after surgery, 0.13%. And we also asked about injection patients and energy therapy patients who had also very low numbers. All of these cases were mild, none required hospitalization, and there were no deaths. So the first column just repeats what I told you about the study in LA. And the second and third column is the first time these numbers have been seen, which is the result of an Aesthetic Society poll, which hopefully you answered a week ago. And in the middle is the whole nationwide data, and on the right broke out just by California, only for interest because we have the separate LA data in the leftmost column. So nationwide, the Aesthetic Society members provided information on 18,803 cases. It's interesting that the testing percentage was very high in Los Angeles at 95.5%, a little bit lower through all of California at 87%, but nationwide 70.5%, which probably reflects different availability levels of testing, different concern in the community, and different rates of disease in the community. It's fascinating to me that it was 0.69% positive in LA and 0.63% positive for all of California. So that's a pretty reliably close number based on very large numbers of patients. It was a little higher nationally. And then the post-op positives were 0.13 in LA, 0.5% for all of California, and 0.24% nationwide. But we didn't look, these are separate studies, so we can't look and explain why that difference exists. Next slide, please. So we also looked at COVID in our employees, because this is about the risk of spread of the disease, not only the risk of safety to the patients. So 9 out of 112 surgeons had at least one positive employee, but only 6 cases were from work. 1 was a nurse infected by a surgeon, 1 was a fellow possibly infected by an attending who they thought got it at a meeting, and the other 4 had no details. But there were no outbreaks in any offices. There were all mild cases without hospitalizations or deaths. Next, please. So thoughts about it. It has the same shortcomings of every survey, which I'm sure you all know. But the sample size was very large. We don't know when those postoperative cases were infected. Did they have a false negative test? Did they get infected after the test? Did they get infected during surgery? We don't know that. Were there more postoperative cases? Likely because only symptomatic people after surgery might have had the test because there were no routine postoperative tests. What's interesting is to ponder the false negatives. The true positives and even false positives were recognized and they didn't have surgery. Those 41 did not have surgery. But if, let's say, there's a 20 or 30% false negative rate, then 8 or 12 patients might have had surgery who had COVID. And what's exciting about that is none of them went on to have hospitalizations or death or serious problems. We did not ask important procedural details about infection control policies in each office. And that would be very interesting to know. So we don't know exactly what the special sauce was that made this so safe. I believe that Quad A and AAA should mandate collecting this COVID data and make it available on a dashboard for all of the members to look at so that we can plan accordingly for the future. In summary, in LA, we documented 5,663 surgeries with no serious COVID-19 infections in either patient or staff. I think we can conclude that plastic surgery is safe for patients and staff even during a period of a rapid uptick of cases, and there is no rationale whatsoever for regulators to restrict plastic surgery during surges. It's not about their perceived importance of plastic surgery, it's about whether or not it is safe, and it is. Thank you.
Well, Steve, that was fantastic. And, it's really great work on that. And I know you're writing up the Aesthetic Society portion of the survey, which is really kind of still in progress. So I just wanted to ask you briefly on, you made this point, but I think it's a really important point. It's about the false negatives, because the PCR test, even the CDC's PCR test, is known to have about a 35% false negative rate. And your data in the 5,600 patients, probably, as you said, 150 plus patients that were false negatives, that were thought to be negative but were positive. So can you reiterate again what you think the important take home of that is for plastic surgeons and their patients?
The take home is that the more patients who had surgery who were COVID positive are actually the ones who prove that surgery doesn't give you a worse case of COVID than you would have gone if you did not have the surgery. At the same time, I disagree with the 35% false negative. I think you have to define what a negative and a positive are, and it's a long tangent. But if there is viral RNA in the swab, PCR will find it. The problem is that patients shed various amounts of RNA through different parts of the respiratory tract at different times of it. There are sampling errors with the technique in collecting them, but PCR will find it if it was in the specimen vial.
Yeah, no, I think that there's some, a whole host of things that are out there, but the truth is, I think it is, we can argue about what the rates are. I think the original CDC test did have a 35% proven false negative rate, but there's, the point is there is false negatives, and I think your conclusion is accurate. So, so thank you, and we'll get more comments from you. So I want to bring in our clinical experts, Mindy Hawes, Brad Calabrese, and Heather Furnas. So I'm going to start with you, Mindy. Why don't you provide some kind of preliminary comments on these presentations and maybe your clinical perspective, especially with regard to kind of where we were in April to where we are now.
Hey, Bill. Hey, everybody. Hope you can hear me all right. In April, we were all terrified. We didn't have any information. I sit on the medical executive committee for my 10-room OR, which is multi-specialty, primarily ortho, but also general ENT and plastics. At that point, Nashville did not have capacity to test everybody when we went back to the OR on May 4th. So we decided to test only ASA3s, people that we were worried about a post-operative COVID case would complicate their recovery. Mary and I have tested our tummy tucks because we worry about DVTs and a post-operative problem with COVID and a tummy tuck. ENT has tested everyone because the worry is spread in the OR. Since that time, we have done over 2,100 surgeries in the 10-room OR. We have tested 9% of those patients for ENT that were all tested with a 2% asymptomatic positive finding, consistent with the community, and 10% otherwise. So 19% were tested. Nobody else was tested. Over 80% were tested. And we've had no post-op COVID problems, cases that we know of. So again, we have sort of a hybrid model where we're testing people at risk or people who risk us. And we found the same thing. It's not been the issue because these are primarily healthy, happy people. But it has changed things, and it's changed things in our office as well. We've had a couple of people who did get COVID in the surgery center, none of whom got it from work. We've had 2 people in our office who have contracted COVID, both from somewhere else. Both of my staff members in the office were in the office the day they tested positive for 4 hours in a mask. Neither of them gave COVID to another staff member or another patient. So mask work and checking for symptoms and talking to patients about what their symptomology is, screening works. That's what we found.
Brad, what do you think?
Yep. Yeah, as Mindy said, we were all scared coming into it. And, I think one of who was scared was my employees. And I've talked about this before on some of these webinars, and trying to get my team back in and be full force with our patients. I felt confident that we were going to be able to monitor our patients well. I have a very large spa in addition to our operating rooms. And I have 65 employees. So there was a lot of moving parts that I think we were concerned about. And so we still continue we've temperature checked every patient that comes into our office, both spa and OR. We just got great devices now. They're actually just standing there, and you just walk up to them and it shows a green light or a red light on their temperature, so that we don't have to have a person standing there now after 3 months of having to pay for an employee to be able to take temperatures. And for the OR, we have had 3 positives out of 200 tests in the last 3 months. So we have about a 1.5% positivity rate. So I think that just falls in line with everybody else's. But that being said, clearly false negatives and or anything else. We've had no patients at post-op have any positive tests. And so what we find is that, at least in our community, that, there's a low number of patients who actually have COVID right now. And so we are safely doing surgery and absolutely having no catastrophes associated with that. I do test everyone. And I would just say the last thing I'll say about this is that, for me, part of it is just the optics as is associated with all of this, not knowing very much. We all had a lot of ideas, but really with no good data to support those ideas. I felt it was best to take an approach, just like I do with my anesthesiologist, that I board certified anesthesiologist. I wanted to make sure that we were perceived as not cutting corners, not being all about the money as a plastic surgeon, but actually being about safety. And so we took that role throughout our office with 1,000 things we did, including testing. And so I think one thing it did great for us, which is for our anesthesia group that covers 5 facilities, and for all the nurses and CRNAs that come with them, they all see our facility now as being the safest. We had the N95 mask, we had all the shields, we had everything they needed, and including testing all of our patients. And that was really just a good PR move on our part, because they all see us now as being the facility that has been the most careful, the most cautious moving forward. And I think that's probably appropriate, because guess what? We're doing something that's not necessary. We're doing cosmetic surgeries. So do I think their testing is necessary? Probably not. I think this data is going to really help support that if we decide not to continue testing in the future. But I do think in the beginning parts, I think it's been very good to test, even if it's not perfect, for the optics and for our own security, and feeling like we can feel comfortable in our own environment that patients aren't coming up positive and that they're doing well with surgery.
Yeah, and Brad, I mean, you employ 70 plus employees, throughout your practice and your spas, and so I think it's a great attestation to just following a process. And one thing I remember that I don't know if we look back on this and we think it's going to be all that fun, but I remember in April, the one thing that I enjoyed is hearing what Brad was going to cook every night, because he's quite the chef, but he never cooks, but he had time. And so, then I was telling my wife, well, Brad's cooking this. Like, she's like, wow, that's pretty good.
We would definitely give evening reports, because we were all talking basically daily of what I'd actually cooked for that night. So, I know how to cook pretty much everything, but we get busy. I probably had not cooked, really cooked, for years, years, and so it was, I think, some positive things come out of it.
Yeah.
Out of, spending more time with family and friends and all that. And I just am so excited. I hope everybody that's on the call gets it. We are so excited to have this data and to reinforce the fact that what we're doing, we can do safely and securely. And I think that gives us a great power. If there's ever problems in the future as it relates to this, having this data behind us is going to be really, really helpful.
Let me say something. The data in LA may have occurred during a period of rising cases, but it was also during a period of high sphincter tone among surgeons.
Yes.
And we were very fastidious about what we were doing and screening patients and the number of people who could come in the office.
Yes.
If we celebrate, we will get complacent and have problems.
Yes. I couldn't agree more. Why we've been super careful. We spent a ton of time thinking about how to be careful and be cautious. And I don't want people to let their guard down. I don't know about testing or not testing. Once we have data, then I think our data can support that maybe we don't test. but, you know, temperature checks and questionnaires, because there are going to be sick people in the communities, and there are going to be people that will test positive, and then a few days later will get very, very sick. And we don't want to miss those patients. The point being is that we can find those probably without doing testing. We can do it through questionnaires and through temperature checks, et cetera, and through what their travel behaviors have been and what their exposures have been. We can do that safely. I think it's a great point, Steve.
Yeah.
But I want to ask Brad and Mindy something. Brad, you've had 1.5% positive of those you've tested, and Mindy, your OR had 2% positive of those who were tested. Those are actually scary high numbers.
Mm-hmm.
If testing were, other than availability testing, if testing were available, what would be your argument for not doing it, or would you be doing it if it were available?
I'm the one who's not testing everyone because we don't have capacity in Nashville.
Would you?
But if we did have capacity and I might get results back in 24 to 40 hours, yeah, I test everybody. I would love to have the data. Wouldn't it be great to be able to follow this data out? You know, it's like doing urine pregnancy tests when every woman comes in for surgery. It would be just something we did, and I would like to see us get to that point. So
Yeah,
I don't have any
Brad,
problem with testing.
Brad, why don't you make a quick comment, then I want to go to Heather.
Yeah. What my point would be is that for the 3 people that tested positive out of 200, I was thrilled that I knew they were positive and that I could not do surgery on them. I was happy about that. So in a way, I'm happy. We have no problem with testing the way we test. We get all our results back in time. It's $99. So for us, it's just an easy venture without any negative side to it. So we do it.
Okay, so Heather, I'm going to get a comment. I just want to say before you give us some insights. Really appreciate you coming on because there's fires burning all around, Heather. And
yes.
So thanks so much for taking time out and sharing some of your expertise.
Yes, thank you so much, Bill and Jamil. It's really an honor to be here. And you mentioned the fires, and that actually adds to the COVID concerns here. They predict that with the fires, our numbers are going to climb. They're climbing already, but the air is really awful. They say it's worse than Beijing. And so they predict that a lot of people will develop respiratory illnesses, and those with them will worsen, and people will be coughing a lot more. And so even with masks, everyone's wearing masks, that the virus is likely to spread. So, and then a lot of people are evacuated. Some of our employees are evacuated. And so the firefighters and the evacuation centers concentrate people. And so we do expect numbers to go up. And so we do test everyone. If we didn't, our anesthesiologists would not operate. So we basically followed the local hospital rules. And so 5 days we test it 5 days, and then we ask patients to isolate until we get the results back. And as our numbers went up, the testing centers were overwhelmed. And so we had to cancel surgery. We didn't get the test back. And so I'm part of the COVID task force, and I'm grateful to Doctors Furneaux, Lund, and Thorne for spearheading it. And so I just pitched the question in the group: how can I get these results? And so they recommended Microgen, which is a home test. You can order it, and it costs $100 per test. It's a home sputum test, and they say that they have an 99.4 accuracy rate. So I don't know about positives and false positive, false negatives, but it comes with a FedEx box that you unfold, you mail it in, and we've gotten results within 3 to 4 days. You just go on their portal. And today was 5 days. We almost had to cancel, but they've been very reliable, and it's much less expensive than our local testing. And so we also, just as Brad, you were describing, you're a safe center. And so we have the same policies. We actually have a lot of our staff working remotely And we've got two tools that allow us to do that. One, we use a phone system called Ring Central so that the phones can ring on our staff's like iPhone or landline, whatever phone they want. And then we do virtual consults. We do a lot of follow-up virtually, but all of our new patients are done with an app called Clara, capital K-L-A-R-A. I have no disclosures. And everything interfaces with Nextech. It's all HIPAA. And so we video chat. We can send them information. They can send us photos ahead of time. So we're just talking. We're not examining. We're just talking. We've got the photos. And our conversion rate has really jumped. It's, from about 75 to 80% to 90%. People are really motivated. It's so convenient for them, and it really compresses our day. So we found it's much more efficient, much better use of our time. So that's actually a plus to come out of COVID.
Let me just say that since Heather said that maybe not surprised because Paco and Heather and I are great friends, that when we use Microgen DX2 and we had the same experience and it's $99, they send it, we can have it drop shipped to the people's house if they were from out of town doing surgery, or they come to we have a whole ton of them in our office and we hand it to the patient to do it at home closer to surgery, or if it's close enough, we do the test with them. It's a saliva test, which we may not have mentioned, PCR saliva test, which has been shown to have as good or better results with getting virus as it would from a nasal swab.
So I want to I'm going to kind of run through some rapid fire questions, and we're going to get to the Q&A from the audience. But so Brad, Heather, you both use Microgen PCR. You kind of talked about who you test, which is you guys test everybody. Steve, what are you using?
I have used Microgen DX. But you do get the delay of shipping, and there's still the lack of clarity about saliva versus sputum. Most of the time, we have a lab in Los Angeles that does a 24 to 48 hour turnaround. I have another lab that'll do a same-day turnaround. And twice when we didn't have tests, I know somebody with an Abbott machine that bailed me out with an Abbott, but I wouldn't operate in my climate, in my community, without getting the test.
And who are we missing? Jamil, what do y'all do testing wise?
So we've been fortunate here with the public health system that it's been relatively straightforward to get access. So outside of the first few days when that system was getting up and running, we've tested pretty much everyone. There's been a sporadic couple patients that haven't got tested because they've been in very significant isolation for weeks to months. But for the most part, everyone's gotten it. Interestingly, Mitch Brown led a study with about 5 of us, a 6-week collection period, close to 500 patients getting aesthetic surgery here in Ontario. And almost everyone was tested. So there were no positives preoperatively tested in the entire cohort. Everyone gets active screening, as you guys are recommending. And then no one has converted or become positive in the 30 days post-op. So that's going to be published, I would say, in the next month or two. And then also, none of the staff at any of the facilities that the surgeries were done tested positive in the period and 30 days after.
And then Tom, you're just doing no testing, just symptoms and temperature checks.
Yeah, I'm just doing a questionnaire, symptoms, temperature check. We do on the morning of surgery, we just do a quick pulse ox, a little fingertip battery operated pulse ox, and that's it. I'm not even sure I need to be doing that, but I do it anyway. What the heck?
Yeah, and our experience, is we publish it, but now it's up to 1,500 cases, and we do temperature checks and screening, and then we do test high-risk patients. So, for example, I had a nurse that worked in one of the COVID units in one of the hospitals here, and we touched her, and I actually used LabCorp. That seems to work. Because LabCorp does a PCR, and it's we do that 48 hours before, and we've been able to get those back before surgery. So that's
and Bill, that's an important point. If I'm talking about my patient population is a very low risk patient population. If you're
for sure.
operating on a patient population that is a higher risk, such as trauma, reconstruction, something that has to be done in the face of a higher risk patient, then once again you have to up your game. You have to test. You may have to do whatever it takes to make sure that that a higher risk patient isn't going to get sick.
But as Heather and Brad have reminded us, there are two issues. There's the issue of the patient, whether you miss an infection in a patient and they get a worse COVID from the surgery than they would have otherwise gotten. And issue two is whether you expose yourself, your anesthesiologist, and your staff. There may be a relationship, but those are two separate issues that have to be handled separately. And, you know, when I hear 2% positive, that's 1 out of 50, none of my nurses or my anesthesiologists would want to be exposed to that. And I wouldn't want to expose my staff to 1 in 50.
2% positive. I don't want 2% positive, Brad, in your series. Is that were they symptomatic patients? Or were they symptomatic?
No, totally asymptomatic.
Yeah.
Totally no, because we would have already been wiped away from us. We would have tested them if they had symptoms. We would have gone, take them away from the pre-op appointment anyway.
And the thing is that the transmission for asymptomatic patients is extremely low, and we also know that asymptomatic patients aren't going to have an issue with surgery. So,
whoa! I don't think you can say that asymptomatic patients won't have an issue with surgery, and I don't think that you can say that asymptomatic patients don't spread the disease. I don't know enough
I can tell you.
I'm not going to contradict you. I will say that I've heard from authorities the other thing, that asymptomatic spread is the sine qua non of SARS-CoV-2 and is the reason that we've had so much trouble containing it. So I think it would be a mistake.
No, I think the point is that asymptomatic patients have been shown that the viral load emitted from asymptomatic patients, if it is emitted, it's very small compared to a sick patient. And that's the important point. That's the important point. And the second thing is that we know that there's 35% of flu patients are asymptomatic, and you operate on them. And if there's all this data, our study, other studies have been done, some of the people that aren't testing here, I mean, you're operating on some asymptomatic COVID patients. It's just by the sheer number. So thus far, we haven't been able to show that that's a negative.
I don't accept that asymptomatics can't spread, but remember, an asymptomatic patient with a low viral load that's getting intubated is different than asymptomatic patient with a low viral load who happens to be in the supermarket.
Yeah, but that doesn't happen with flu, 35%. So I mean that you have to go with what you know. At least that's what we know at this point.
Well, you don't know that. I mean, every anesthesiologist and every nurse that works in a hospital gets a flu vaccine. And by the way, some of them also get flu. So for all we know, they are getting it at work or not getting it because they've been vaccinated. We don't know that flu people don't give the virus in the OR.
The point is that if they're asymptomatic, they're still being operated on, and they're not having complications, and it's the symptomatic people that are at risk for having a problem. And that's what's been borne out from this data.
The only people I would worry about would be the people that are you catch before they're getting symptoms. So there's asymptomatic, which means they never get symptoms. They go on. They have a low viral load. That's who they are. There's also the patient who gets exposed, is positive, but will get symptoms, but has enough viral load. And you catch them in a place where they still haven't shown symptoms or significant symptoms. 40% of patients don't have a fever, and yet they can catch it. So it's just that group of patients. I agree. If you're asymptomatic, there's probably a chance you have a different virus or a low viral load. But there are patients who I hear from patients who've had COVID who were exposed, and because they were exposed, had a positive test, because they checked it, because they're family members, and they went in this latency period where they were kind of doing okay and thought they were through it, and then they got sick, like their family member did when they checked it. So I think there is that, but I'm sure that's the exception, not the rule.
And I think it's important to note that if we knew every patient was going to be honest about their exposures, then because we had a nurse 2 weeks ago who we tested because her husband was symptomatic, and we were testing him, and she was not symptomatic, but within 48 hours was terribly sick, and 15 days later, she still can't sleep without sitting up. So those are the people you don't want to miss. And that, if I could test everybody easily, I would do it.
Those are what we call those are pre-symptomatic.
Pre-symptomatic, absolutely.
Yeah.
But you don't know that till after they're post-symptomatic, right?
Yeah.
So at the time.
And the newspapers today just were saying that we're looking at asymptomatic numbers because that it looks like the viral numbers are increasing because of the asymptomatic patients. So when we test, I'm actually, because our patients are low risk, but I'm particularly concerned about the staff, and particularly the anesthesiologist who's putting in the LMA or the ET tube.
That's an interesting point. When we first talked about this, there was discussion that LMAs should not be used and only ET tubes to protect from shedding. But we've been using LMAs, and I'm curious what the rest of you are doing.
LMAs. Actually, that's not true. We use LMAs for all surgery except for above the neck, and then we intubate for surgeries above the neck.
Our anesthesiologists use kind of what they would typically use for whatever the case may be. So there's not a differentiation. Okay, we're going to run out of time. I just want to, Jamil, before you talk about we shift gears, is there any questions that you've seen that you want addressed by our panelists?
And just a quick one. Someone asked, Brad, where'd you get the stand-up temperature check? What's the name of it?
I wish I knew. I don't really know, but I can send that out. We just got it a day ago or 2 days ago, but it's really good. We'll find out. Let me see if I can find out real quickly before we leave.
With 69 employees, you must have quite a line to get into the office in the morning, Brad. My God, I'd rather get into a Tokyo subway.
Yeah, exactly. Well, I'm not the first one there, no surprise, so I wouldn't know. But anyway, yeah. So, they get temperature checks. They get temperature checks in their stations. They don't come in through the front door and check. Each manager is responsible for checking their team.
And Sue, do you want to put up our poll while we're kind of closing out this Q&A? We've got a few poll questions for the audience to get your input on. So any final comments from any of the panelists before we switch gears? Everybody's too busy looking at the poll. All right, well, listen, that's great things from all you. Really appreciate you guys sharing those insights. And with that, we're going to turn it over to Jamil Ahmad to give us an education update.
Great, thanks a lot, Bill. So thanks for everyone for tuning in tonight. We've been busy in the background, as you can imagine. It's been a really busy year since this all started for our education team. And Sue, Debbie, Tiffany, Kathleen, Pamela, who've all been great. We've had to plan probably a total of maybe 10 or 12 meetings and then replan them as the situation changed. So the latest is our Experience Insights Breast and Body Contouring Symposium that was going to take place in Dallas on September, I think, 11 to 13. It was going to be live, but we've shifted to a different format that's going to be virtual. Bill, can you forward that slide for me? And so it's going to be September 12 and 13, and there's going to be very interesting program, 12 CME credits. You can review it after. Let's get the next slide. And we have Pat McGuire and Caroline Glicksman, who are co-chairing it. It's going to be a great format, different than most of the other virtual meetings that you've seen since this pandemic started. We'll get the next slide. We have a diverse group of faculty in the next slide. And what's going to be interesting is we're going to, in the flavor of past breast and body experience insight meetings, hit on the hot topics in breast and body. So we're talking about BII, BIA, ALCL, breast fat grafting, soft tissue support, and then also talking about breast reconstruction. And then with body contouring, obviously high definition liposuction, new innovations in abdominoplasty, and then an emphasis on different aspects in plastic surgery for patient safety, including an update on where we stand for fat grafting to the buttock. And we'll get the next slide. And this meeting has always been quite different than all of the other meetings, that we've really tried to make it very, very interactive, and to have presentations that really get in depth on topics. So in that spirit, we've had a hybrid type meeting. We're going to have live in studio. So some of the faculty will actually be in Dallas in studio to have some of that interaction that's going to be live streamed, and combine that with virtual faculty presentation as well as you, the attendees. And we have a format where we have a very in-depth insight followed by a contrarian's presentation and then analysis of the topic, debates, expert video pearls, and then quick hits. So don't miss the program. It's going to be excellent again, and you can see it on the Aesthetic Society website. Let's get the next slide. In keeping with planning virtual offerings, in November 2020, we're going to have a Saturday course that's going to be 3 hours of injectables with live injections, followed by 3 hours of premier global hot topics. We're going to present all the latest technology and innovations, and we'll have great industry participation for that. And then we jump on to the Face and Rhinoplasty Symposium, which is going to be January 2021. We've been running that for a few years in Las Vegas. We're going to go to interactive panels and discussions in a virtual format this year, and also have Look Live Surgery again. So I'd encourage you all to join us in September for Experience Insights Breast and Body, and watch your emails and social media, because you'll see the dates coming in November for the injectable and hot topics, and also for the January Face and Rhinoplasty Symposium. So with that,
Jamil, I got one question for you. Is that, so people register via either the email links or the website?
Yep.
And is the registration a la carte, or does it include all those, or how does that work?
For Experience Insights Breast and Body, it's one registration fee, and you're going to be able to engage each of these separate programs separately, and also the on-demand content. So even if you can't tune in on the day, you can review these courses to get both the educational experience and the CME on your own time for the next half a year or so.
I have an answer for our temperature thing, just so before you leave.
Yeah, go ahead, Brad.
Yeah, so it's called Thermo Health, and you can get it at thermohealth.us. So it's an infrared technology. It's $350. So we thought that was a great deal, and it actually has a green light, so you can, as on the front desk, they can see the green light. But if they actually go over the temperature, then it's a red light and a siren, and it sounds really great. So anyway. So,
yeah, and every time Brad walks into the office, it just goes on fire.
It does. It's like hot. So anyway, that's the information there. So for anybody that thinks they want to move to that, it's really great.
And Dr. Adams, we have the poll results if you want me to share those.
Yeah, that'd be great. So it looks like 83% of people are pre-op testing, 17% are not. And then 4% of people have had somebody on their staff test positive for COVID that was work-related. And then actually of the positive tests, the vast majority of those, 23% were not work-related, which is funny because that's what it seems like anecdotally, that's what I've heard from my colleagues. But still, the majority, 72%, have not had their staff test positive. And then only one person, 2%, had a patient hospitalized for COVID within 14 days after surgery.
Hey, that person, please call me tomorrow. This is Steve Teitelbaum. I just want to hear what happened to the patient, because I'm writing this thing up, and I would love to know, and I would keep it confidential. Thank you.
You know, one thing we didn't talk about, and I just want to say it real quickly, is that I think that, you know, as you're thinking about it, you maybe a policy we put into our office that people may consider, it has to do with the behaviors of our staff members outside of the office, both their travel history, what they're doing, if they're posting in social events, because we've had some of that problem with all of a sudden you'll have somebody posting and they're at big events with no masks on and everything else. And, you know, they have a real responsibility to our office and to our patients. And so we have a policy in place that we have the right, they have to get pre-approval if they are going to go to a state that has too high of a conversion positivity rate currently, and have our approval before they do it, that they're socially going to be responsible for that. So I think those kind of policies are great to have in place just to protect yourself when you feel like you need to intervene at some point.
Brad, I've heard that from a number of other surgeons since I've done this, where they've had positive staff, where the staff, I mean, a lot of the staff is young and are not being responsible.
Yep. So we have a policy in place that we just to make sure everybody knew where we stood on that. So we don't say it mandates they have to take a 14-day quarantine. We just say we reserve the right to, you know, they need to have pre-approval to know the situation.
And interestingly, as the last comment, you know, the residents, like our residents at Southwestern, they're basically told that if they have a non-work related positivity, that they won't be paid unless they want to take vacation time. So
interesting.
Yeah. All right. Well, listen, it's the top of the hour, so we want to really thank everybody for attending. I want to again thank our speakers for doing a great job, and lastly, thank Sue Dykema for running the show. And again, sign up for the upcoming meeting on September 12th and 13th. I think you'll find it fantastic, and I hope everybody has a great night.